Welcome, everyone, to the One Payer States presentation on our state organizing work, working toward passage of universal healthcare systems at the state level, which is complemented by the work that we're doing with the State-Based Universal Healthcare Act, which if you haven't already caught it, please check that recording. The two work hand in glove, the work that we're doing at the state level, which is our focus today, as well as the work that we're doing through Congress to get enabling legislation, super waiver legislation. Ro Khanna's HR 6270, and Ed Markey will be soon introducing the same exact legislation in the United States Senate. So check out that other recording, and that works to feed off of what we're going to be discussing today. And you can watch them in any order you wish. So my name is Chuck Pinocchio. I'm president of One Payer States. We've been around since late 2009, so 15 years. Our organization has been focused on working together, collaborating, sharing ideas among and between now 25 states. Today we're represented by Peter Shapiro in California, Bruce Thompson in Oregon, Steve Auerbach in New York, and Consuelo Echeverria in Washington State. But just know that there are another 21 states that are doing this work. And we were also planning, it may even be in the document, to have a report from Maine, but our presenter there was unable to make it because of a family situation. But we're going to be hearing from four of our leading states, and very excited about that. Let me just give you a few minutes of background on One Payer States, who we are, why we do what we do. The mission of our organization is to achieve the gold standard in single payer work, and that is to get to a national, improved and expanded national Medicare for all system. This is our goal. And the idea of our theory of change is that the likelihood is that it's going to come up through the states. It may happen on the national level, but we can't see that happening in the immediate future just because of political circumstances. But at the state level, we have a number of states that are rich with opportunity. And the idea of getting the SBUCA legislation, the State-Based Universal Healthcare Act, passed actually has broad appeal. And we can, with the way that we frame it, can bring a lot more members into supporting that legislation, and that super waiver legislation is intended to provide support for states to implement really strong universal healthcare systems, single-payer healthcare systems, Medicare for all systems at the state level. And this also speaks to the fact that Canada was able to get to national Medicare for all through a single model of a province, that being Saskatchewan back in the 1960s. So this is not unprecedented. And in fact, the work of progress in the United States on political, social, and economic reforms has more often than not started at the local and state level. Take a look at the progressive era, the New Deal, the Great Society. Almost all those programs were modeled at the state level. Before they became national law. So this is the focus of our work. We work on healthcare justice, but we also work at the intersection of all health issues. We are mindful that we can't have an effective healthcare system unless we have a healthy society. So we work in coalition with numerous social justice groups. In fact, 75 of them, national, state, and local, are supporting our work through our petition work, as well as our lobbying and education work. So this is really an exciting time for the work that we're doing. And let me just say that, so as we fight for an improved and expanded Medicare for all plan that works for all residents of our nation, we should really look to support these state initiatives. And that's what we're asking you to do today, to go to onepayerstates.org, onepayerstates.org. Check out the work we're doing. Consider supporting us, joining us. We're always looking for volunteers, financial support. We have work groups that focus on policy, education and advocacy, communications, as well as development and organization. So please consider joining our work. And this is a prime time to be thinking about moving forward again at the state level. And then we're really, really excited to have the presenters today with us. So first up to be presenting is Peter Shapiro from Oakland, California. Peter, tell us what's going on in the state of California and what folks there can be looking for, and folks around the country. Thank you so much, Peter.
Well, I'd love to start off with some good news. Unfortunately, last week, actually it was last Thursday, AB 2200, which is our single payer bill, which cleared the Assembly Health Committee by a 9-4 vote with 3 abstentions back in late April. It was basically killed by the Assembly Appropriations Committee, despite the fact that the chair of the committee probably could have pushed it through if she really wanted to, has represented herself as a single payer supporter, and in fact has been a co-sponsor of past single payer bills. The reasoning behind this is that California is facing a big, now there are some cuts in the for a lot of programs, and even though, you know, we single payer advocates have argued that this would actually save the state money up to, you know, as much as almost $500 billion over 10 years, according to a state-funded study that came out a couple of years ago. Over time, the immediate financial impact of just simply launching the process would make some demands on the state budget, presumably, and that was all it took to kind of dampen any enthusiasm for the bill on the part of the legislature, at least the Appropriations Committee. I obviously don't share that, you know, but I know that it's 10 times tougher when the state's facing a deficit and a lot of things are being cut to get anything through. The AB 2200 is actually, this is the third effort in about 5 or 6 years that we've had. We had SB 562, which actually made it through the Senate and probably would have made it through the state assembly back in, I guess, 2017, was it? But the Speaker of the Assembly, presumably because he didn't want to embarrass Governor Jerry Brown, who would have had to veto it, pretty much did not allow it to come before the Assembly. He claimed, well, there's no financing language in it. There actually would have been financing language in it, but the report that spelled it out in detail from the PERI arrived a little bit too late, a little bit after the hearing had happened. Subsequently, the California Nurses Association, which has been really the driving force behind single payer work for a long time, longer than I've been in California. They had basically operated through a coalition for SB 562, which they provided the leadership from. Once it failed, I think they decided to pretty much work on their own and draft a bill on their own and then ask people to support it, which is what they did. First, it was AB 1400, which actually did make it to the assembly floor, but then the sponsor withdrew it because he realized the votes were not there. And then AB 2200, which is a somewhat stronger and better, I think, version of the same bill. And I told you what happened there. Actually, I didn't even make it to the floor for a vote. AB 1400 and 2200 are different from earlier bills in one particularly significant way, and this is something that the One Payer States Policy Work Group has really hammered home: is that that there's a fundamental inconsistency between having a single payer system and allowing HMOs to continue to operate. That it breaks up the risk pool, that it sacrifices the administrative savings, and it encourages discrimination. Those are the three arguments. And this is a problem in California because 1 in every 4 Californians is a member of Kaiser, which is probably the mother of all HMOs. And not only do they wield a lot of political power, but it's like people want to know, well, what's going to happen to my coverage? And there are a lot of question marks, I think, about how Kaiser would continue to operate under a single payer system as it's laid out in 2200. On top of which, Kaiser has collective bargaining agreements with probably close to 100,000 workers, and they're not all in the insurance division. Kaiser is really 3 entities. There's the insurance plan, there's the Permanente Medical Group, which does outpatient, and then there's the Kaiser hospitals. The plan of AB 2200 was to have global budgeting for the hospitals and fee for service for the Permanente Medical Group, and the insurance arm of it would disappear. And frankly, nobody would be sorry to see it go. The question is how it would continue to operate as a healthcare provider once that was done away with, and there were a lot of questions raised about that. The other issue, and this is kind of a chicken and egg controversy, I think. What do you do first? You try to go to the federal government and see what they will tolerate in a state plan, because 40% of California's healthcare dollars come from the federal government, either through Medicare or Medi-Cal, which is our version of Medicaid, or several other programs. And clearly, it would be any single payer program that did not capture that money would be laboring under a real disadvantage, you know, even in a fairly wealthy state like California, which is like the world's fifth largest economy. So CNA basically pointed out that legally, under the Affordable Care Act, the federal government will not approve any state single payer plan, will not approve any waivers for a state single payer plan until a policy bill has been passed. Healthy California Now said legally that's true, but it's still important to start talking to the feds now and see what they'll agree to, even if nothing is written in stone about it yet. Because if you don't get that settled, or at least get some sense of how it's going to be settled, the legislature is going to be a lot more squeamish about it, because it could be a huge bite out of the state budget. Another complicating factor is that we have a crazy tax system in California, thanks to Proposition 13, which passed back in 1978, the infamous taxpayers revolt, which mainly benefit corporate property owners. But it made it very difficult to get new taxes imposed in California. It takes basically a 2/3 vote of the legislature, or it has to pass the state with a ballot initiative. And the whole ballot initiative process is horribly abused in California. It's mainly, big money really dominates even more than it does in particular legislative races or office races. So this is something we're going to have to deal with no matter what. And it's the question of timing, what the best strategy is to get it through. And I should mention also that Healthy California Now basically adopted a strategy based on the findings of a commission that was appointed by the governor and the legislature several years ago, called the Healthy California for All Commission, which was supposed to investigate how to implement what they call unified financing, which it may be a polite way of saying single payer, or it may be a devious way of saying single payer or something else which masquerades as it. There's a lot of controversy about that too. But they did hold several months of hearings right in the middle of the COVID pandemic. Their deliberations produced a couple of really very positive results. One was a poll of low-income Californians, which showed overwhelming support for single payer, and even if it means dismantling Medicare and everything else, especially in communities of color. We're talking about 70% of the people polled. And the other was a study, the first time I know of a state-funded study that actually crunched the numbers and concluded how much money single payer would save. And I mentioned their high figure was like $500 billion over 10 years. And even if long-term care were included in the benefits, that study concluded that it would still cost less than we're spending now. Of course, that presupposed that we would have access to the federal dollars that make up 40% of healthcare spending in the state. So Healthy California Now basically tried to pick up on what was positive. That's a coalition that formed following the defeat of SB 562, and I'm on its board. Basically, the coalition tried to operate on what was positive in the deliberations of the Healthy California for All Commission. Specifically, Governor Newsom, who ran as a single payer supporter back in 2018, but is a notoriously unreliable ally. It authorized, we were able to get a bill through the legislature, which mandates him to negotiate with the federal government over the whole issue of waivers. It also sets up a process whereby stakeholders would have some input into what they would want to see in the bill. And the coalition has been having monthly meetings, where people who may not yet be fully committed to single payer, but are open to it, get a chance to weigh in, to express their issues, that kind of thing. And the process will presumably begin in earnest in January, and with the idea that by January of 2026, we would have a fully developed bill, and we could make a formal application for waivers. SB 770 was, it did get through the legislature. It was passed. The governor signed, the governor didn't have to sign it because basically it was a mandate from the legislature for something that he was supposed to do. And CNA did not take kindly to it. They felt it was undercutting their efforts. There's been a lot of bad blood and a lot of friction over it. And my own take on it is that it should not have happened. That people are basically arguing over things that are not what they used to, what the Chinese used to refer to as non-antagonistic contradictions. People can disagree, but they can still work together. And I think that's been a real obstacle. And I think probably it owes a lot more to process than to policy. The question of how an organization like Kaiser would function under a single payer system, I think, there's a lot more work to be done to figure it out. And I hope that more people, will be engaged in that process and figure it out and come up with a bill that can get broader support. I should say that AB 2200 did get support at the last minute from the State Labor Federation, which is a pleasant surprise because they gave no indication they were going to do that before. It got support from the two statewide teachers union and the California Faculty Association. And it was supported by Unite Here, Local 11 down in Southern California, and their president, Ada Briseño. Those of you who have attended some of those national conferences are probably familiar with her. She's just been a fighter for single payer and immigrant rights for a long time. And she has appeared, on national single payer forums. Unite Here, the national union, has gotten a lot more active. And they have recently joined the board of Healthy California Now, not just a local, but the international union. Their position on AB 2200 was what they called supporting in concept. They said that this can't happen soon enough to suit our members. We are making huge sacrifices to protect our health coverage, and we just don't want to do it anymore. They did issue a letter where they raised a bunch of questions, which probably should be taken seriously, whether or not one agrees with them about what they thought needed to be improved in AB 2200. And I'm sure that those questions, I actually posted it on the website of One Payer States. I sent it out to the One Payer States Work Policy Google group, and I'd be happy to send it to anybody who wants to read it. It's interesting. I don't think this is a time for me to go into details. It's too deep of a dive into the weeds. Yeah. But they're an important union, probably as much because they played a huge political role, I think, in defeating Trump in 2020. When most of their members were on layoff, they just sent them out into different swing states, ringing doorbells. They represent mainly low-wage workers. They're hugely important in they basically organize the hospitality industry, and they're very progressive generally, as much as CNA is, although they don't have quite as much in the way of resources. Yeah. So I think they're a group that would really be important. Same is true for SEIU, which is not as progressive, but which represents a hell of a lot of Kaiser workers. Some way is going to have to be found to get them on board too. Personally, my concern has always been that if we want to muster the resources to counter the kind of crap that we get from the healthcare industry and the insurance industry and the hospital cartels, we're going to need labor support. Really, not simply verbal support, not simply a resolution passed at the union convention, but putting some muscle behind it, some lobbying power, some money, everything.
Well, thank you for your frank report. Appreciate it, Peter. Next up is Steve Auerbach, Dr. Stephen Auerbach from New York, and he'll lay out for us what's happening in the Empire State. Steve?
Hi. So yes, welcome from the Empire State. We hope to decolonize the Empire State as soon as we can. So here in New York, we've had the New York Health Act for many years in the New York State Assembly, led by Dick Gottfried. And one of the big changes is he just recently retired after being the longest standing legislator in history, state legislator in history. He's still doing well personally. He's now on the PNHP New York Metro Board. But the turnover has been a chance to, kind of reevaluate a little bit of how we do and what we do here. So the New York Health Act is, I would argue, a true universal single payer, covers everybody who lives in New York State, regardless of their immigration status. Also, importantly, and this is something I think all state bills are going to need to address, it covers folks who live out of state but work in New York if they are working full time. So folks who may live in New Jersey or Connecticut, but work full time in New York City or New York State elsewhere, would be covered. And of course, if folks are living in New York, they're covered. If they are living in another state, working in New York, they're covered. And flip side, if they are living in New York and working in another state, they're also covered. So those kinds of details, I think, do need to be worked out. In the case of New York Health Act, comprehensive medical, dental, mental health, devices, hearing, vision, drugs, long-term care, both nursing home where necessary, and preferentially home care, and progressively paid for. One of the positives I think that we in New York are going to be pushing more, and I think all single payer activists should be pushing, is how much cost savings it is for all lower levels of government. So in the case of the New York Health Act, city and county governments save a ton of money. One of the other benefits is publicly accountable and transparent decision making. It creates a board that regulates and does the rate setting. The board has representation from all the stakeholders, various patient groups, but also physician groups, hospital groups. It's all spelled out that they are represented and vote on it. The language in the bill in terms of reimbursement rates specifically says they have to be sufficient to provide adequate supply of healthcare workers. In New York, it has passed the Assembly in previous years. It passed 4 straight years, 2015, 2016, 2017, and 2018 in the Assembly with 2-to-1 majorities. We have a bicameral state legislation. Frankly, the only reason it was allowed to be voted on and the reason it passed with such overwhelming majorities in the Assembly is at the time the Senate was de facto controlled by Republicans, and so it was known that it would never come to a vote. Now that we have a large Democratic majority in both the Assembly and in the Senate, and despite the fact that the bill has a majority of co-sponsors, a majority of both the Assembly are signed up as co-sponsors, a majority in the Senate are signed up as co-sponsors. If not this year, then in the immediate years past. Despite that, it basically has not been allowed to come to the floor to a vote. Has not been allowed to come out of committees. And the reason is that the majority leaders in both the Senate and the Assembly basically control what's allowed to come even through committees, and they just don't want it to come out and push the governor's hand. We have by my standards, a very conservative governor currently. We had a complete corporate conservative governor previously, Cuomo. And, simply as a matter of doing politics and transactionalism, they don't want to force the governor to either actually support it, God forbid, or veto it. So despite the fact that we have these nominal majorities signed themselves up as co-sponsors. It doesn't come forward for a vote in recent years. Nominally, the issue that's holding it up is that several of the largest public service unions, the teachers unions, various unions that represent various other city, state, county public workers are opposed to it. Ostensibly, they're opposed to it because fear of change, fear of losing the benefits that they've negotiated. There's some sense that there's some transactionalism is a polite way to put it. Others would use less polite words for why they're opposing it, or at least why, if not their members are opposing it, the union leadership is opposing it. And then that in turn gives the Democrats in the state legislature, well, if public service unions aren't going to support you, we can't support you. As is the case in California, our strongest support from unions is from the nurses union. New York State Nurses Association, NYSDA, has been a big supporter. They're the ones that helped introduce it years and years ago through Dick Gottfried. I should say that several of the doctors unions, which we do have here, Committee of Interns and Residents, supports it. And we have other unions that have supported it. But the reality is that at least public facing, the opposition from the public service unions is what's holding it back. The good news is that we have been successful enough that we have a corporate dark money group opposing us. So I consider that good news. If they're not openly resisting you, it means you're not even considered that much of a threat. So we have a group that's called Realities of Single Payer. And you can look them up as Realities of Single Payer, all one word.com. That's opposed to the New York Health Act. It's the corporate interest that you would assume is opposed to it. Here in New York, we use the acronym FIRE for finance, insurance, and real estate. So the FIRE interests are all opposed, of course. I do think there are some legitimate questions that either needed to be answered and have been just in recent years, and that I think other states need to look to as well as they move forward with state-based single-payer bills. There is that issue of state adjacency and having people who live in your state but work outside of the state. In the case of the New York Health Act, they're covered. Then there's the folks who live out of state but work in New York State. And again, we've clarified that if they work full-time, defined as over 32 hours per week, then they're covered. As many of you may know, in 2018, the RAND Corporation was deliberately hired as a center-right group, was deliberately hired to do the analysis, the economic analysis for the New York Health Act. Gerald Friedman at the University of Massachusetts had done an analysis in 2015. But it was challenged as, oh, well, that's a lefty advocate. We want something more independent. And so, the RAND Corporation, nobody's idea of a left-wing group, was hired, and they did a very honest and as it turned out, very positive job. So our big issue here in New York has been winning the unions, the public service unions over, publicly to win them over. And to get the word out that the current system doesn't have to be the way it is, that there is a better way out there, and that New York could help lead the way. We could be the Saskatoon of the United States. And I would encourage everyone who's interested to please go to nyhcampaign.org. So that's NY like New York H like health, nyhcampaign.org is our general activist group. And we have a strong and broad coalition within our PNHP group, PNHP, nymetro.org. We're open to everybody. You can reach me personally, and I'm welcoming, and I'll help connect folks at dr.stevea@gmail.com. So Dr. Steve A at gmail.com.
Terrific. All right, Steve, thank you for that. Appreciate it. Steve, that was excellent. I really appreciated your discussion on New York, especially the public service unions. I think that's a challenge all of us need to really take seriously. And so thank you for that presentation. So at this point, we're going to pivot and hear from Oregon through the great work that Bruce Thompson's doing. Bruce is based out of Corvallis. Bruce, thank you.
Well, thank you, Chuck. I appreciate this opportunity. I've been working on healthcare reform probably for the last 15 to 20 years. As a practicing family physician, I was increasingly frustrated and morally injured by the increasing restrictions that in private insurance company put on how I would care for my patients. So that is my driving force behind this. And presently, right now, we're being invaded by Optum and United Healthcare Group. Just recently bought our local clinics, 70 physician clinic. So I'll go back just a little bit historically to 1989 when Oregon developed a prioritized list of reimbursements for ICD codes. And that was a process of community engagement. Meetings were held throughout the state to inform people of this prioritized list for what would be covered for the Medicaid population. And I'll go fast forward to 2012 when Oregon established 16 coordinated care organizations spread across the state once again for the Medicaid population. That program has brought interesting comments that as we move forward for universal health care, we want our services to be similar to what Medicaid pays for patients, because it's so expansive about what actually does get paid for in our state, at least. So we're going to move from the 2012, the CCO formation to 2019 when our Senate Bill 770 was passed and established a governor's task force to examine the place for single payer for universal health care. So that was in 2019. The original assignment was for the task force to get started in July in 2019 and to report to the legislature in January of 21. September of 2022, the task force forwarded their reports and recommendations to the legislature. That was in September of 2022. In October of November of 2022, Oregon passed Measure 111, which as part of a constitutional amendment, stated that it was the responsibility of the legislature to assure that all Oregonians had access to high quality, affordable health care as a human right. So the first state in the nation to have passed such a legislation, constitutional amendment. In 2022, Senate Bill 1089 was passed, and that was to abide by the task force recommendations of establishing a governance board to figure out financing and administration for a universal healthcare system in Oregon. So that governance board just started meeting in April of this year. They've had a couple of meetings, well, three monthly meetings, and their report is due to the legislature in by 2026, I believe it was. Not only is the governance board charged with figuring out financing and administration for the universal health plan, but it's also charged with figuring out a transition plan for the universal health plan, recognizing that a transition from our current healthcare system to a universal healthcare system is going to be a very bumpy ride. And so the governance board is actually charged with figuring out that transition plan. The funding, as the task force recommended, the funding would be through a public trust, health care public trust, separate from the general fund. As far as coverage, yes, all people who lived in Oregon, regardless of immigration status, would be covered. People who live in Oregon, work in Washington would be covered. People who live in Washington and live and work in Oregon a certain number of hours would also be covered, similar to what Steve was talking about. So that is where we are at the present time, in short order,
Okay.
as promised.
Yeah, terrific, Bruce. Appreciate the brief presentation. All these states, California, New York, Oregon, so far, very inspirational. Consuelo Echeverria from Seattle, Washington. Consuelo, who's a new board member with One Payer States. We're grateful to have you with us, and would love to hear your report. Thanks so much again, Bruce and Consuelo. You're up.
Hi, thank you so much. So just 2 seconds about me. I'm an artist. I lived overseas for many years in a country that had universal health care. When I moved to the United States in 2010 to take care of my mother with dementia, it didn't even occur to me after 22 years of living in a country where health care was covered that I needed private insurance. And it wasn't until I went to graduate school to get a master's in public health that I was asked, oh, do I want insurance? And I was like, oh, that's right, insurance. So that's a little bit of background on me. I want to talk a little bit about something that's happening in Washington State that not very many people are talking about, a little bit of a landscape analysis that just kind of sets the stage. Since 2017, through a federal waiver, just so happens, our healthcare authority, Washington State Healthcare Authority, has been moving 90% of all of their contracts into value-based purchasing contracts, meaning everything from rural healthcare to our public option, which is called Cascade Plans, to the teachers and the Public Employee Benefits Board, PEB and SEB, to our poor folk, which is Medicaid. They've had the goal to push all of these programs into value-based purchasing contracts with ACOs and MCOs. So it's really not surprising at all that two pieces of the two pieces of state-based legislation, a beautiful bill, which was really just aspirational by Senator Hasagawa, that just asked the Washington state to call on the federal government to create a universal health care program. And if the federal government was unable to do that, to at least put forth SABUCA, right? That little teeny aspirational bill with no budget attached didn't pass. And then it was even less surprising that Keep Our Cares Act, which was a very big and important bill, which tried to regulate consolidation of healthcare entities like hospitals, hospital systems, and provider organizations, that didn't pass either, even though it passed the Senate in a midnight session on the last day it failed to pass the House. They just kind of let it die. So as a newcomer to this, and as someone who doesn't have 25 years working in healthcare policy, I feel it's really important to reach out and bring the stories of people who are impacted by our crappy healthcare system, to elevate those stories and to use them as motivational factors to fight. If Levi's and Budweiser can tell a story in 30 seconds that brings you to tears to make you buy their products, that's what we're fighting. And that's the kind of strategizing I'm thinking of. And to that date, we actually have a wonderful unsung hero here in Washington State, which is called it's an organization of a coalition of about 75 different organizations, including labor. Healthcare as a Human Right is the name of it. And we actually put on a first rally for universal healthcare in March 6th, where we had labor and the teachers union, the nurses union, health care advocates, lawyers, Senator Hasagawa, another senator, Senator Kuderer, actually come and speak. And it was the first time in Washington State that these organizations actually got to see each other all together on a stage. And I think that those kind of events, while they might not have a lot of legislative impact, they do work to activate the landscape. And out of that now has come a coalition of groups that are very active, and we're thinking about what we're going to do next. So I think that that's it from me.
Excellent, excellent. Consuelo, appreciate that very much. And yeah, this is very powerful work that you're all doing. Reports today from California. Thank you, Peter. Steve Auerbach from New York. Thank you, Steve. Bruce Thompson from Oregon, and Consuelo from Washington State. Hopefully this has been a lot of good information to chew on for you folks who are listening in on this pre-recorded session. And can folks contact you as well, Cello? Where's a good place?
Oh, absolutely. It's Consuelo, CONSUELO at hcfawa.org.
And Bruce, how can people reach you? mchuntington@gmail.com, MCHUNTINGTON, mchuntington@gmail.com to learn more about what's happening in Oregon, to connect with Bruce if you have a question specifically for him. And Steve's left his contact info, Peter's left his, and you can reach me as well at cpinocchio@gmail.com, or just go to our website, onepayerstates.org, to learn more, to help, to learn, and to share. This is a group effort. We're all in this fight together. We all want to get healthcare for every single American, every single resident, every single person within the United States, and catch up to the rest of the world. This is shameful that we're not there yet, but this is the fight that we're taking every day, every way, building organization, working with legislators here in Washington, D.C., back in state capitals and across the states, our consortium of 25 states. So thank you to our friends at Healthcare Now for putting on this conference, this Medicare for All Strategy Conference. Really appreciate that, and all of our partners in the fight. We're going to win.